Now, so ketamine, as we know, is a dissociative anesthetic. So we've been using it in medicine since 1960s, So at high doses, it's an anesthetic. At low doses, what ketamine does is it boosts glutamate production in the brain, basically, and that improves neuroplasticity. It stimulates the formation of brain-derived neurotrophic factor and all these other neurochemicals in the brain that increases plasticity in the brain. So it helps with rewiring of the brain. So that neuroplastic window can then be used therapeutically to help folks with chronic pain and depression and other conditions. Anti-addictive effect, the way we use it, because it's a brief dissociative mystical plane kind of experience with high dose. And we've seen from the literature, there's quite a few meta-analyses coming out to show that ketamine can be used for alcohol use disorder, cocaine use disorder, cannabis use disorder. So we've actually seen in our own research here that a lot of patients quit drinking. They significantly reduce using alcohol. The interesting thing with these psychedelics is they also seem to work as anti-inflammatory agents. So they've got an anti-inflammatory effect on the brain. It seems to be in an inflammatory state in the brain with chronic pain and with mood disorders. So there's been a few studies by Nichols et al. Where they looked at that as psychedelics as anti-inflammatory substances. The other thing is ketamine, of course, works directly on pain receptors. It works on these NMDA receptors, and it decreases sort of the activation of these receptors, and that also reduces the chronic pain experience. For cancer patients, I see a lot of potential end-of-life distress and anxiety. I mean, as they say, if you've got the right to die, you have the right to try. Antidepressants, like SSRIs, oftentimes just push down the negative feelings. You just push them down, and you just don't want to deal with them, and it's
like suppressing it and
suppresses it long term. Nothing gets fixed, but you feel kind of superficially okay, but it doesn't really change your world. You don't get the insights. How do you get insights? It's just basically suppressing all the negative stuff.
Cures, Remedies, and Beyond podcast with Dr. Arena, a Stanford-trained medical doctor, inventor, and a published author with over 30 years of clinical experience, is bringing together the science of medicine and the art of healing for ultimate vitality and health. It engages in discussions with healthcare providers, wellness experts, innovators, philosophers, spiritual and industry leaders, as well as health and wisdom seekers to provide you, the listeners, with practical tips and knowledge to help optimize your health and well-being. The Cures, Remedies, and Beyond podcast with Dr. Arena.
Today our topic is the use of psychedelics like ketamine in treating depression, anxiety, and PTSD. In the United States, 1 in 5 adults, about 57 million people, struggle with mental health issues such as depression or anxiety, with only half receiving treatment. In Canada, over 5 million adults are affected, and globally, 970 million people, almost a billion people, have faced similar challenges. These numbers worsened significantly during the pandemic with a 25% spike in mental health disorders. Recent studies from places like Johns Hopkins and Columbia University have shown promising results using psychedelics such as psilocybin and ketamine for mental health treatment. Johns Hopkins University's Center for Psychedelic and Consciousness Research is leading groundbreaking studies on psilocybin for treating depression and smoking cessation. Columbia University is pushing boundaries with ketamine, particularly in combination with ECT, or electroconvulsive therapy, for severe depression. They found this combination has been shown to reduce depressive symptoms by 60% in patients who had not responded to other treatments. Psilocybin, a compound found in magic mushrooms, enhances serotonin activity and has been shown to relieve depression in 70% of trial patients, offering rapid improvement where traditional medications often fall short. From boosting neural plasticity to calming the brain's fear center, these compounds are reshaping and revolutionizing how we approach mental illness now. To explore this topic, we've invited a distinguished physician, chief medical officer, and co-founder of the therapeutic clinic, and the leading researcher at the Bill Nellums Pain and Research Center in Canada, where he's advancing the understanding and application of psychedelic-assisted therapy for conditions such as depression, PTSD, and opioid dependence, Dr. Francois Lowe. Thank you so much for joining us, Francois.
Thank you so much, Irina, for the wonderful introduction. And it's just great to be with you. And it's a topic near and dear to my heart. So I'm very happy to speak about this. And hopefully our listeners can, learn about some of the new research endeavors and see how we do it in Canada. And I'm very happy to share our experience with everybody.
Yeah, well, you're obviously a physician who is not only specializing now in these novel treatments, but your background was emergency medicine. Now you're a specialist in chronic pain and opioid addiction, etc. So, but I was really impressed when we met and talked at the conference a few months ago, where you presented on the use of ketamine, which, to be honest, a lot of us doctors have no understanding, no clear understanding. How does it work, and what are the current scientific understandings, what is this ketamine? What is psilocybin? And how do they really impact the perception of pain, mood, etc.? So please enlighten us, Francois.
Absolutely. You know what? I've been, as you rightly said, I've got a long background history with some of these medications, such as ketamine in the ER and also the OR. I used to do anesthesia for years as well, and so we've got understand the medication well. But my interest in this field came about because I've been seeing that with interventional pain treatments and with counseling and pharmacologicals, there's obviously something that's missing. We're treating a lot of the biomedical problems for patients, and they get better to a large extent if you say do a facet injection or a nerve block, or you do PRP if they're knee. But a lot of times there's layers to their pain, and there's a big psychosocial part of the pain where there's, obviously the pain experience can affect mood and can affect sleep and so forth. And my feeling is we can't just sort of focus on the biomedical without really looking into healing their minds, and we need to really find a way to bring in some other modalities to address that well. So that's why I started getting interested in and adding that modality to our clinic treatments. And so in our clinic, we use ketamine-assisted therapy in a very safe psychotherapeutic framework with a multidisciplinary team, nurses, doctors, psychotherapists, psychiatrists. And we've also brought in some of these other psychedelics that people might have heard of that seem to be quite, a popular topic of discussion, such as psilocybin and also MDMA, which one can do in Canada at this point in time through a special program. So I can certainly, tell you more about those different options.
Yeah, that is a pretty hot subject, obviously. I mean, we do know that there are a lot of ketamine clinic. I mean, there are ketamine clinics literally in the United States. There are like 500 to 700 clinics all over the country. So, but ketamine also known for club drug, right? So it can be used as a recreational drug, right? So, but in your setting, obviously, you have a clinic. You guys do it as a medical treatment, with amazing results. But can you explain how does it? I mean, what's the difference? Number one, like between ketamine and psilocybin, for example, right? So, I mean, do they act on the brain differently? So and yeah.
Yes, I'm happy to sort of elaborate more on that, Irina. So ketamine, as we know, is a dissociative anesthetic. So we've been using it in medicine since 1960s, So at high doses, it's an anesthetic. At low doses, what ketamine does is it boosts glutamate production in the brain, basically, and that improves neuroplasticity. It stimulates the formation of brain-derived neurotrophic factor and all these other neurochemicals in the brain that increases plasticity in the brain. So it helps with rewiring of the brain. So that neuroplastic window can then be used therapeutically to help folks with chronic pain and depression and other conditions. So that's ketamine. Now, psilocybin is sort of a classic psychedelic. It works on the serotonin receptors in your brain, the 5-HT2A receptors to be specific, and it has the same effect on neuroplasticity, which is I'm really interested in neuroplastic agents because I think it's really helpful for multiple conditions. But psilocybin works directly on the serotonin receptors. But it basically, in the end, if you look at the downstream effects, it does help with neuroplasticity as well. And the good thing about psilocybin is that it is an anti-addictive compound. So it is used for addictions, where ketamine, as we know, can be used as a drug of abuse. And unfortunately, it has been. And I'm very careful with that. And that's why we only do treatments in our clinic. There's no sort of ketamine that's taken at home. I really don't think that's a safe model. And we screen patients very well from a medical perspective and also a psychological perspective before patients are able to become sort of patients receiving the ketamine treatments. So that's basically in short the difference between the two.
Yeah, and I mean, ketamine, of course, is known for some out of body experiences, so is it a dose dependent type of, as you mentioned, reaction? And in your clinic, you're not really targeting that. So you're using different doses that people are not experiencing that. I'm just curious.
Yeah, you know what, Irina, in our clinic, we use the intramuscular route. We do use higher doses. There are, it's all dose dependent. At lower doses, one could use ketamine in a psycholytic fashion. So it actually softens the ego defenses. So one could sort of use ketamine, say, in a sublingual format with a counselor or psychotherapist. So it softens the ego defenses. It's easier for patients to talk about different or difficult topics. So it improves the psychotherapy, it improves the success rate. At the doses we use it mostly, we use a higher dose, a psychedelic dose, which is a dissociative dose, because the research shows that to get a really good therapeutic results for someone who suffers from, say, significant depression or PTSD, the higher doses seem to be translating to better results. So it's if patients reach a sort of a mystical plane or a deeper plane where they sort of gain insight into the problem, and patients are in a sort of a comfortable place, supported by a healthcare worker, but they get to this plane where the brain can undergo the neuroplastic changes without them necessarily having the opportunity or the potential to sort of really experience distress. I think that higher dose seems to really translate to the better results, and that's what we're using for most of our patients. It's a higher dose intramuscular session.
And you mentioned that looks like it's very important to have the psychotherapy alongside, with this type of substance.
Exactly. Yeah, we feel that, this idea of sort of treating and treating patients or at home ketamine treatments without proper psychotherapy, in my opinion, it's just really, it's a recipe for problems, because a lot of difficult subject matter can come up in these sessions. And it's very important to build a safe container, as we call it, to ensure that there's preparation counseling, there's integration counseling that sort of bookends this dosing session. And I think that is a safe way to provide the service.
Yeah, that's very, very interesting. So it sounds, obviously you know what you're doing anyways there. So, but how long would the positive, effect, antidepressant or whatever effect you're trying to achieve for a patient last? Like after one session, for example? Or
Yeah, that's a good question. Patients will obviously feel with that glutamate release. Well, by the way, glutamate is the neurotransmitter in the brain. That's a main excitatory neurotransmitter. Where GABA is the main inhibitory neurotransmitter. So you get a boost of glutamate, and that immediately improves the mood. So that's why at our local hospital, this treatment is also used intravenously for patients with acute suicidal ideation, because you get an immediate boost that works basically within 2 hours. And then what happens is you get this opening of a neuroplastic window in the brain that can last for a week, maybe 2 weeks, during which time it's really helpful to sort of do the goal setting, change behaviors, get psychotherapy that gets to the core of the problem, and just really use that open neuroplastic window to bring about some lasting changes. So with psilocybin, that window is open for longer, probably 4 to 6 weeks. That's why I think there's going to be interesting research coming out on that front. But it seems to be a bit longer of a window that's open. But the effects clinically seem to outlast that neuroplastic window. Lots of patients seem to be doing well for even longer than that. But it often needs to be repeated in the future with some follow-up visits. And that's sort of just a brief sort of summary of how we do it.
Mm-hmm. And does it have any addictive qualities? Like, do people who do multiple, you said like sometimes people require more than one treatment. So are they hooked afterwards or not?
That's a great question. And the good news is I'm very against, addictive medications. In fact, a lot of my research has been centered upon getting patients off opioids. And for example, at my pain clinic, I've got 0 patients on chronic opioids now. So I'm really interested in getting people off of medications that are habit forming. So ketamine itself in a framework where it's very tightly controlled. And of course, we screen out patients that have a significant current history of abuse of drugs or medications. But we have not seen any significant addictions. And we do harm reduction, of course, at all times. But we have not seen that happen. And in fact, it has an anti-addictive effect, the way we use it, because it's a brief dissociative mystical plane kind of experience with a high dose. And we've seen from the literature, there's quite a few meta-analyses coming out to show that ketamine can be used for alcohol use disorder, cocaine use disorder, cannabis use disorder. So we've actually seen in our own research here that a lot of patients quit drinking. They significantly reduce using alcohol, which is kind of an interesting signal I've seen from our 300 patients that we've sort of studied now over the last 2 years. So from that perspective, I think it looks promising. But yes, if one uses it on the street and you use large amounts, then of course, there's definitely that risk. But then it's usually those folks that use drugs and ketamine in that way usually use a dose that's 20, 30 times higher than what we would use, because it's high amounts, large amounts over a long period of time. People get ketamine bladder. It is a different topic altogether. It's like any medication. If you use anesthetic agents at home, like say propofol, like unfortunately with Michael Jackson, I've used propofol in the OR for decades, but if you use it at home, it's a completely different ball of wax, as we would say. It's very unsafe. But if you use ketamine in a specific clinical framework with oversights in place, with guardrails in place, we have not seen addictions in our population of patients.
It's amazing that actually can help people with addictions at specific doses and in appropriate setting. So yeah, and the propofol, as you mentioned, of course, can at specific dosages as an anesthetic stop the breathing centers, right? So that's how Michael Jackson, unfortunately, uh, passed away. But does ketamine have the same effect on the breathing brain centers?
No. Ketamine does not suppress the respiratory centers in the brain. So we use it. It's used widely, of course, internationally as one of the safest anesthetic agents because it does not suppress laryngeal reflexes or respiration as opioids and propofol and those things would do. But if you look at a case, and I think it's probably the elephant in the room, and that's the Matthew Perry case, and people probably always wonder what happened there. But that was, unfortunately, he died, but it was co-ingestion of multiple substances, including alcohol and benzodiazepines and likely opioids and ketamine. And then, you get this, it's a toxic cocktail. It's not supervised. And that is something that I'm really, firmly against. I think it needs to be done very safely. And co-ingestion of all these other substances might cause issues, especially the way that, unfortunately, that unfolded. Yeah.
So sad. You also mentioned because you obviously treat people with the chronic pain, and you use this treatments for the chronic pain patients. And how do psychedelics really work differently than they do for strictly psychological disorders?
Yeah, it's a good question. But the interesting thing is the brain pathways dealing with mood disorders, depression, and it's also chronic pain are very similar. So that's why there's such overlap between chronic pain and depression, probably 65, maybe 70% overlap, because it's the same brain centers that are involved with the centralization of pain. And by that, the listeners, we mean then if one, your acute pain, say an arthritic knee becomes, a chronic pain condition because the brain pathways get sensitized. And the psychedelics seem to work on that central nervous system part, the spinal cord and brain pathways that get sensitized with chronic pain. Because our patients ask me, doctor, why do I not get immune to the pain? If I had this pain, I should be able to take it and soldier on. But people get sensitized so that the pain gets worse and worse over time. So ketamine and psilocybin seem to work on that centralization, the central part of the pain, works on the emotion centers of the brain, probably the prefrontal cortex, where you sort of give meaning to the pain, and it sort of decreases that whole process on a central nervous system brain level. Yeah.
So that's definitely, an issue. That's why chronic pain becomes more and more chronic, and the threshold changes, for the pain perception, and the people experience the same stimulus can be experienced in a much more heightened way.
Exactly. And we see it in our pain clinics, all the time. And the interesting thing with these psychedelics is they also seem to work as anti-inflammatory agents. So they've got an anti-inflammatory effect on the brain. It seems to be in an inflammatory state in the brain with chronic pain and with mood disorders. So there's been a few studies by Nichols et al. Where they looked at that as psychedelics as anti-inflammatory substances. The other thing is ketamine, of course, works directly on pain receptors. It works on these NMDA receptors, and it decreases sort of the activation of these receptors, and that also reduces the chronic pain experience. So just to give the viewers and listeners an idea of why we seem to want to use ketamine, because it works on all these different mechanisms underpinning chronic pain.
Yeah. So neuroinflammation is a big topic these days, right? So because there are a lot of conditions that can cause it. So, but can you share any success stories or case studies where psychedelics, significantly improved chronic pain or treatment-resistant depression or some other mental challenges?
Yeah, that's a good question. I think, quite a few case studies come to mind. I'm thinking of a patient who is in our clinic now, and she is 42 years old, and she's had pain for about 20 years, and she's not been able to work for about 10 years as a result of chronic pain. And it's multifactorial pain, low back pain, neck pain, myofascial pain. It's a wonderful lady, and she also unfortunately has had some issues with PTSD and depression. And we started treating her initially, of course, with the usual interventional pain treatments with ultrasound guidance, and that got her to a good place. We did facet injections for neck pain, and I think we did a epidural for chronic back pain. And then we also did for PTSD, a stellate ganglion block, which calms down the sympathetic nervous system. It's actually quite a useful intervention, I find, for PTSD. And we've got a few studies, mostly by the author, Dr. Mulvaney, and others looking at some, great outcomes there. And I use it every day. So we did that. And then we sort of got this patient into the ketamine treatment program. So we did 2 intramuscular ketamine treatments, and she's doing, and that was about a year and a half ago. And I think we recently did a 3rd treatment, and she's done so well. So socially, she's much, much improved. She's much brighter when we sort of visit. She's thinking of doing some part-time work. She's doing advocacy work for patients with chronic pain. She's actually helped us with public education events to sort of spread the word. So significant decrease in pain, and she's sleeping better. And it's just, just gratifying to see that. I mean, that's what we're in this field. We love to help. We love to see people, just improve from a physical and a mental health perspective. And that's been heartening to see.
Yeah, definitely. Wow. Especially she's even looking for work. I mean, for job, so that's really empowering. I can see that. So, but yeah, we actually did have a podcast with Dr. Sean Mulvaney, as you mentioned. So we actually have another episode on that, specifically on the stellate ganglion block, as you mentioned. So is there like a synergistic effect between the stellate ganglion block, obviously, that quiets, the sympathetic discharge with ketamine, or they just work on 2 different pathways? How do you see it? I mean,
I've been wondering about that myself. Why does it seem to be synergistic? I think lots of folks, when they come into the clinic, there's a lot of apprehension, there's anxiety, and if patients have sort of significant PTSD, I think the stellate ganglion block calms down that hyperreactive sympathetic system, which reduces, in my opinion, sort of this fear response in the amygdala in the brain. And then once that's, calmed down, so to speak, to an extent, the effects of the ketamine treatments seem to be improved. There's also a better journey throughout this journey, which, by the way, lasts about an hour or so in the clinic. There seems to be less anxiety and apprehension. And for me, it's so important. If patients walk in, I want to make sure that they feel welcome, they feel calm, they feel safe. And I think if we pre-treat folks and we decrease that sort of hyperactive sympathetic response, the psychedelic treatments seem to actually work much better.
That's really impressive, I have to say. Yeah. And of course, one of my questions is side effects. Could you share any insights on the safety profile of ketamine and psilocybin? I mean, especially, of course, when it's used under the medical supervision. Obviously, when it's used in the street, you don't know what's happening. But I just read some studies that the especially heavy use, so multiple repeated use could slightly alter the density of the receptors, like serotonin receptors in our brain, for example, and maybe potentially affecting mood regulation, afterwards. Or, I mean, did you see any any changes, so short term or long term?
Yeah, that's very important to note, because, let's first look at the exclusion criteria. Patients who should not do either ketamine or psilocybin as patients with a strong history of, a personal history of schizophrenia, because there's an increased risk of psychosis with these medications. Of course, pregnancy, patients with significant intracranial like pressure issues like brain tumors or a history of seizures, patients with significant cardiovascular problems like high blood pressure or significant angina. We would screen out or be careful with patients because we want to keep them safe. We don't want to have these high blood pressure surges, which we can see with ketamine and psilocybin. So we want to either pre-treat folks, make sure the blood pressure is very well controlled before we get people in. Another potential contraindication is if patients don't want to change their worldview. If patients are, and one of my colleagues, succinctly put that, if you are happy with your worldview and you see the world in a way that works for you, it might not be a good idea to disturb that, to destabilize that. So that's an interesting contraindication in my opinion, but I think it's something to consider. The side effects we see generally in a treatment program, like in a clinic setup, I would say the risk of nausea is about 5 to 7%. Vomiting, we see maybe in 3 to 5%, maybe 3% of cases. So it's probably the most common side effect. And of course, then there's the short-term issues with equilibrium. You don't want to get up too quickly because people feel a little tipsy. And then, of course, there's headaches that are short-term, very short-term kind of phenomena. Maybe a little bit of increased anxiety initially when you get into and you feel the rush come on and you sort of go on your journey. There might be a little bit of that fear of letting go. So, of course, patients are instructed to, trust, let go, and be open to the experience. And they're well supported by someone sitting right next to them. And I think that makes a huge difference in that sort of anxiety that patients might experience initially.
Do you guys, I'm just curious, do you collect the journeys? As you said, people have certain, mystical experiences and go through, I guess, certain journeys. Do they remember those journeys, by the way? And do you collect the stories?
Yeah, we do. And yeah, it can be very vivid and very interesting. It could be entertaining for some patients. And for some patients, it could be, it could be a tough journey. It can be really rough. And we tell folks neuroplasticity is not neutral. It can be really difficult material that you need to work through. But sometimes it's quite light and it depends on various factors. But we do encourage patients to talk to the psychotherapist the next day about this so that there's integration of the experience. So we do that within 1 or 2 days. Because right during the session, of course, the patient is recumbent with headphones and eye shades, and there's really no time to do any psychotherapy during the experience. We just, of course, have a nurse who keeps patients safe and comfortable. The insights come a little later, so we do then the integration counseling the day thereafter usually. And then we encourage our patients to discuss what came up, because otherwise, who's going to help them unpack it? You need someone who's professional to help patients unpack the experiences, the insights they might have gained, and then they can build on that.
A perfect combination therapy sounds like.
It is.
And Francois, how does psychedelic therapies compare to traditional treatments like antidepressants, so serotonin intake inhibitors, as we know, obviously, or opioids in terms of effectiveness and safety?
Oh, that's a great question. There's been quite a few studies out of Johns Hopkins, Imperial College London, looking at at, various, psilocybin, of course, and versus escitalopram, which is, there was a study by Robin Carhart Harris. And escitalopram, of course, is a SSRI. And the results were actually very similar with just these big doses, with the psychotherapy, the psilocybin journey experience. Usually there's 2 of those experiences within a 2-week period versus escitalopram longer term. So the results are very equivalent. But in the long run, patients seem to actually do better with the psychedelic approach because they seem to preserve the emotional range and responsiveness. Antidepressants like SSRIs oftentimes just push down the negative feelings. You just push them down, and you just don't want to deal with them, and it's
like
just
suppressing it and
suppresses it long term. Nothing gets fixed, but you feel kind of superficially okay, but it doesn't really change your world. You don't get the insights. How do you get insights? It's just basically suppressing all the negative stuff. So I think if you look at the research, the emotional responsiveness and the long-term outcomes are better with both ketamine, of which there's more than 24 studies, randomized control trials, by the way, for depression. And there's also quite a few psilocybin studies for depression. And the vast majority of them show good responsiveness. For example, even with ketamine, there seems to be an improvement in mood, even compared to electroconvulsive therapy for patients with really bad treatment-resistant depression. So it's safer. It doesn't lead to the cognitive effects. People have forgetfulness when they get these shock treatments to the brain, and it's still used as a first line for treatment-resistant depression. But ketamine does not lead to significant cognitive defects. Yeah.
Wow, and you also, SSRIs also have a lot of side effects, right? So as we know, there is decrease in libido. There is, in the early initial intake stages, people can even have suicidal ideations, right? So does ketamine have the same side effect profile or not really?
There could be sort of with any of these treatments, if it's a powerful enough agent to bring about change, it's powerful enough to cause side effects, right? So I've never been an unrestrained cheerleader for any of these because there are potential side effects. There's potential for destabilization. There has been some, but fortunately limited increased sort of suicidality in some of the studies with all of these agents, but it's a very small minority of patients. I think in the one psilocybin study recently, I think there was about 3%, 3 to 4% of patients had increased suicidality, which was short-lived. But it's generally very well tolerated, though, very well tolerated at the right doses. But yeah, it will have some side effects in that regard for sure.
That's why it has to be done under, of course, medical supervision and carefully in your clinics and in a clinic like yours, obviously. So
yeah, you know what? I think that's a safe model. There's a lot of people, of course, have been taking magic mushrooms in a more of a party setting for many years, and if it's someone without significant, psychological pathology, with mental health issues, then it's, I can see how some folks might benefit, but it's difficult to know what the outcomes are going to be, and it's not controlled enough. And I would say the more sort of one suffers from mental health issues, the more important it is to do it in a safe psychotherapeutic framework, and that's how we're going to continue doing just that.
What is your opinion on microdosing? Obviously, it's a very popular topic, and you guys using microdosing, or you do like real therapeutic type of doses?
Yeah, microdosing, the jury is out on microdosing. I mean, lots of people microdose, and I think it's relatively benign, honestly. I mean, psilocybin itself it's a very safe compound at very low doses, like 100 to 200 milligrams or 50 to 200 milligrams a day. It's very widely used, and I think if you look at the studies, there seems to be a big expectancy bias, i.e., a placebo effect. I mean, you expect to feel better. You do feel a little better. You feel a little bit, maybe a bit more open, a little bit more of a mood lift, similar to SSRIs, similar to antidepressants. But if you look at it in a real scientific way, we do not have the evidence to say that it is a very robust effect at all. And it might be just down to expecting you're going to feel better, you feel better, and that seems to be what's going on with microdosing.
It's like a placebo type of effect, basically.
I know some people would say it's not a placebo, but there's a big effect. Yeah, it's true.
At a low dose, as you said. Yeah, okay.
Expectancy bias. There's a bias towards wanting to feel better, and people who microdose already self-select themselves into a group that believe in the treatment. So I think we have to be scientific about this and say we've got way better results or way better research on the threshold or macrodose experiences versus microdosing.
Mm-hmm. Yeah. That's so. What do you think are main challenges, like in integrating this psychedelic assisted therapy into mainstream mental health care?
Yeah, I've seen you know what? It's been a few years. We've been soldiering on, but it's been tough because the mainstream is very conservative. And I find it's unfortunate because I'm from the mainstream. I did anesthesia, emerge medicine for many, many years. But I feel like there seems to be in medicine, medicine seems to be, it's a very conservative field and we don't want to rock the boat. But in my opinion, we're just not doing well enough on the mental health field. We clearly are not doing well enough. We have to look at this. It's ethically incumbent upon us to look into this more in more detail. That's why we'll always, keep researching this. But it's been difficult, even in our own local health environment, to get support and buy-in from all the psychiatrists or from family medicine physicians, from referring doctors, because people are just unsure. They don't know what to make of it. So I think there's still a bit of stigma, even now, even in 2025, and we've been doing it for 5 years in our clinic, in our setup. So I really hope that we'll get better studies, larger studies, figure out what protocols work the best, come up with compounds that are even safer than the ones we have now. But I'm firmly convinced that this field of improving neuroplasticity or rewiring of the brain, it's so important to help patients with mental health and with chronic pain struggles. I think it's a big part of the answer.
Well, I mean, it sounds like there are a lot of universities really now working and pushing the field. So like I know that University of Wisconsin had a trial just last year, so that explored low dose psilocybin for anxiety in cancer patients, and the results were quite dramatic. So they showed like 40% reduction in the anxiety scores just after 2 sessions. So, and
I've taken note of that research. Yes, Irina. So that's absolutely for cancer patients. I see a lot of potential end of life distress and anxiety. I mean, as they say, if you've got the right to die, you have the right to try, because in Canada we have medical assistance in dying. And I think, but we don't even have the option to use a compound that's quite benign, like psilocybin, to help our patients go through, the palliative stages with a bit more comfort in their hearts. And I think, for me, it's a no-brainer. We have to open up, at least for folks who are struggling with end-of-life distress, anxiety. I think it's just the ethical thing to do is to provide it for them. There's actually good evidence from Johns Hopkins on that front as well.
It's interesting, yeah. Well, I mean, if we can find anything that helps us to rewire wire emotional responses, right? So, and like ketamine also is kind of increasing the resilience to stress, any type of stress, right? So that, yeah, it would be fantastic if we can see more research, more data, obviously, that can help us to, move this sounds like relatively low side effect treatments. So, giving that it's done in appropriate clinical setting. So, I have another question for you, Francois. So, what do you think of this Stone Age hypothesis by Terence McKenna, who suggested that early humans, were eating psychedelic mushrooms and it boosted their brain activity and potentially sparked the abstract thinking, imagination, and language, even by altering, the neuronal connections, pushing consciousness towards the more complex problem solving rather than, more of a.
I think, initially I thought this is an interesting hypothesis. This is out there, but you know what? I think over time I've been thinking this is potentially true because, I mean, I think when sort of our ancestors developed the sort of the idea that there's more to it than just this, I'm going to hunt down a mammoth and I'm going to, this is just a day-to-day activity, expanding the consciousness, maybe seeing more sort of potential there and sort of the experience on Earth. There's more to it than we see. I think it makes sense. And then even if you look at the old Greeks, the Greeks had these big sort of events. They went to
Delphi?
the Delphi. Yeah, there's
Delphi?
actually a
The
temple. So
mystery?
they went to the Eleusinian mysteries. That's the word.
Oh, Eleusinian mysteries, right?
There was a
Right.
temple close to Athens, and ancient Greeks 500, 700 years ago went to this, and they partook in these ceremonies. I think part of that might be part of this whole genesis of the Enlightenment during that time in Greece. So I think there's something to it. Who knows what happened to our ancestors? But I think there's clearly it's a tantalizing and interesting hypothesis.
Yeah. Well, I was just curious because I remember when you delivered this, wonderful lecture, at our specialty conference, so you showed the fMRNA, I guess, map, so of the, enhanced brain connection. So, before and after. And it was like such an increased amount of connections that, suddenly we could see on that map. That really impressed me.
Yeah, that's right. Yeah. I mean, there's more connections between disparate brain regions. It just disrupts all of those very, just, we see the world the same way every day as when we wake up in the morning, and this disrupts that. And it for a short period of time, it connects multiple different brain regions. That's why you can see sounds and you can smell colors, so there's this overlap, almost like this entropy in the brain, and you get a lot of new connections and new sort of sprouting of dendrites between the neurons. And that's one of the reasons why I think it works so well and just rewiring the brain, so to speak.
And are they kind of stay, or they gradually fade away? So those connections, so in those kind of heightened way of, I mean, probably helps with even some memories or some, I don't know if those connections, or maybe creativity. I don't know, what do they really enhance?
Yeah, also all of these, all of the above, there's increased cognition, increased creativity. I think the initial boost of creativity and cognition is short term. It probably lasts just a few days to maybe 2 weeks with ketamine. But I think some of those patterns get kind of hardwired to an extent later on, and especially with if one does in that critical learning period after the treatments, I think that can be sort of hardwired in a positive way. But yeah, the initial psychedelic effects, of course, are just the short term sort of effects on the senses. But it shows you how all of these brain regions that usually don't talk to each other for, even if it's a short period of time, and then that sort of leads to, increased plasticity.
That's interesting. No wonder our ancestors, you mentioned Eleusinian mysteries, I remember reading that Plato, Pythagoras, they were like big proponents of the Eleusinian mystery, I guess, activities, and have been apparently, known to do that multiple times, so certainly that's how they feel like they were alive, so they couldn't go back.
Yeah, and all of the original philosophers like Socrates, Plato, they were all part of this Eleusinian group, and that those the mysteries or these activities took part over a 1,000-year period, and we still don't know what they took. Probably an ergo, probably some sort of a fungus coming from ergo or rye, but we will never know, because on pain of death, these participants were told that they are not to tell anybody what happened there. But it's of note, all of these ancient philosophers were part of that. So
Yeah,
did it
that's
expand their
really
consciousness? Probably.
right. Out of body experience assistance, right? So here we are. Yeah, that's phenomenal. What advice would you give to someone struggling with chronic pain or depression who's curious about exploring psychedelics as a therapeutic option?
Yeah, I think it's very important to do it with a team that you trust, obviously, preferably someone you've worked with in the past. I would look and make sure that people have proper training through some sort of a accepted group like MAPS. Of course, I think most people know about MAPS, which is a wonderful organization.
What does it stand for?
Multidisciplinary Association for Psychedelic Studies. Dr. Rick Doblin and others who have done all the heavy lifting in this field. So they've done great work bringing the research to the fore. So make sure people are, either MAPS or, there's other groups that basically ensure that there's a proper training. In Canada, there's groups like Therasil and other groups. So I would look and make sure there's mental health professionals involved, whether it's counselors or psychotherapists, psychologists. I would like to see that there's potentially a doctor and or a nurse involved. I would be personally, I do not like the at-home ketamine treatments at all, because I think it's just not safe enough. So I would not support that. And yes, I think, and I think, if I can't endorse microdosing, of course, because we don't have enough evidence for it. I would just say make sure that, the team's well trained, they've got a good track record, they're kind and compassionate people when you meet them. There should be no pressure to do anything. And some of these procedures are done, or these treatments are done at retreat settings. And that might be reasonable for some, but, yet again, I want to make sure there's some medical oversight. If someone has a psychotic break, or they have significant nausea and vomiting, or they have chest pain, or there's a seizure, heaven forbid, which is very unlikely, but, it's possible, I guess. I want to make sure there's some, proper oversight, and there's a safety mechanism in place.
Yeah. Oh, well, that's a really important message. Yeah. And your clinic, if somebody wants to connect with you and your clinic and do it, at your place, would you share how could they find you guys?
Yeah, certainly, Irina. So, we've got a group called Entheomed. It comes from entheogens. Entheogens, of course, are psychedelics. So Entheo, Entheo med, MED. And the website's entheomed.ca. And we're based in Kelowna, British Columbia. It's in the southern part of British Columbia. And potential patients are welcome to contact us, and we can certainly give patients information and help people along.
Yeah, what's the best way to contact you guys there? So email, phone number?
Yeah, if one goes to the website, there's an email address and there's also a phone number. Probably just picking up the phone and talking to our front office staff. They're very, well versed in this. Maybe just give them a call and see and sort of just discuss options with them. I think that's probably the best way. And then sometimes if patients are out of town, we do a Zoom call with them so they don't have to travel all the way in. But of course, all dosing sessions are done in town. Some of the psychotherapy is actually done via Zoom, which we find is actually pretty effective. But all the dosing sessions are done in the clinic, and that's how we do it.
Thank you. Yeah. And where do you see the future of psychedelic therapies heading in the next, I don't know, 5, 10, 15 years, do you think?
Yeah, I think it's going to keep evolving. It's going to keep. There's going to be way more research in the next 5 years. There's going to be more molecules. I think we're going to look at different molecules like DMT, 5-MeO-DMT, short-acting molecules, because the psilocybin journey is 6 hours in the clinic. So I think we're going to look at shorter journeys. Ketamine is about an hour, of course. We're going to see multiple research projects on ibogaine for opioid use disorder. We're going to see more research probably on ayahuasca, which is another psychedelic. We're going to see further MDMA research. Hopefully the FDA will approve MDMA for PTSD, because as you probably know, that was unfortunately not approved, but there were some reasonable issues that made it a bit more difficult for them to approve it. We're doing research in Kelowna at the University of British Columbia. For example, I'm starting to enroll patients right now in a study treating patients with chronic pain that are taking opioids for their chronic pain. The idea is going to be to give them psilocybin, 2 macrodose experiences with psychotherapy, and we are following their opioid use over time. And the hypothesis is that we will reduce opioid use substantially with psilocybin.
Wow, that's amazing. So, and people can contact you as well to enroll, right? So same place, same website.
Yeah, it actually just struck me. Patients are welcome to actually contact our research coordinator, and I can sort of share that. Of course, I stay at arm's length with the recruitment. I'm not involved in that, but we have some patients that are in the pipeline right now that have been screened. This is an open label feasibility study, so it's a small study. We're just going to really look at 10 patients to start with. And it is funded by the Melissa Etheridge Foundation. Melissa Etheridge is, of course, a well-known sort of singer in the United States, and she's kindly supporting that study to help patients get off of opioids. But I can certainly give you some details, and potential patients can contact.
Yeah, maybe a link, and we'll post that link, on the episode description, so that that would be easier. So
yeah, oh, absolutely. Yeah, we'll be very happy to help with that as well.
Well, opioid crisis is such an issue everywhere in the world, really, So, and if 2 microdoses, say, of the psilocybin or any psychedelics under your supervision might decrease that, that's a huge victory. So, I'm looking forward to the results of your studies. Hopefully, they will prove your hypothesis. So.
I think we'll see some real positive results. Having looked at the results with ketamine now over many years, and of course, to do psilocybin is much more difficult in Canada. So it's at present you really have to do it through a research study like this. There's some other ways to get it done, but this is the way to move the needle, is to do proper studies with really good study protocol. And we're focusing on that. Even if it's a small study, we want to do it right, and then we can build on that knowledge. But there's literally right now dozens and dozens of studies internationally on all of these different molecules. So we'll see a lot more research in the next 5 years.
Wow, so we might have a different landscape in 10, 15 years in the treatment of the mental issues. Yeah, so
I hope
that's
so.
really,
I hope so, because it's desperately needed, and I really think we can do better. So for me, it'll just be wonderful to see, if we can come up with more effective treatment protocols. It would be great.
yeah. Well, thank you for such an interesting conversation, Francois. Yeah, I really appreciate you joining us and sharing this fairly new, actually, for me, information. Yeah.
Well, it's absolutely my pleasure, Irina. Thank you so much for asking me, and I will be very happy to give my contact details to anybody would like to contact me, and happy to continue the discussion.
Yeah, great. Thank you so much. And thank you for joining us at Cures, Remedies, and Beyond, exploring science and the wisdom of health and healing. We hope to see you next time.
This podcast represents the personal views and opinions of the host and the guests and does not constitute medical advice. The statements contained in this podcast have not been evaluated by the FDA. Any products or treatments mentioned are not intended to diagnose, treat, or prevent any disease. Cures, Remedies, and Beyond podcast with Dr. Irina is bringing together the science of medicine and the art of healing for ultimate vitality and health.